Hello everyone, welcome to our First Five and Derbyshire Education Network session. And just waving here next to me, we've got Sasha. Thank you so much for joining us, Sasha. We are doing the infant feeding difficulties and maybe some little toddler difficulties popped in there as well, which would be really great. So we've got lots of people signed in for tonight, though, over 30 people. So we know that more people will be joining us, but we'll get started. And the session is being recorded, so we'll be able to share this with people who've missed any bits later. I've had a chat with Sasha, and in terms of tonight, so obviously it's being recorded. So if you can, keep yourself muted unless you've got a burning question, and then please feel free. Sasha is very happy for you to ask your question. The other thing that we've got, as always, is the chat. So do feel free to pop your questions in the chat, and then we can get to them at the end and go through them. So that'd be really nice. And finally, I didn't even say at the beginning, I'm Elise. I know most of you know me already, but I'm the GP task force Den lead, and I also am a GP in Derbyshire. Sasha, I will let you introduce yourself if that's okay. Can I hand over to you?
Sure, yeah. So my name is Sasha Landskron and I'm a registered dietitian. I've been practicing for just over 20 years. The majority of that has been in pediatrics, and I was at Chesterfield Hospital until just recently. I'm also doing a bit of locum work in pediatrics for North Devon Hospital, but I'm here in Derbyshire. So today, we're going to be talking about the whirlwind tour of infant feeding development, reflux, cow's milk allergy, and feeding problems. So there's just an hour, and I want to make sure, because evenings are precious, and I want to make sure that in this hour we cover your burning questions. So if any of you have got some clinical cases or some difficult patients that you've been thinking about, dealing about, or you've got some questions about this you want to make sure that I cover, if you want to shout them out now and I'll make some notes, or if you want to pop them in the chat, that would be great, and then I can just make sure that I cover everybody's questions. So I don't know if anybody has any questions at the moment. If there's anything in the chat here.
I don't think there's anything in the chat at the moment, Sasha, but I will monitor it. So yeah, if anyone's got anything they want to ask and want me to ask in the middle of the session, then just let me know.
Ooh, that would be great.
We've already got one, Sasha. How do we differentiate between colic and cow's milk protein allergy? That's from Agechi. I hope I said that right.
That's a good one. That is a very good one. Okay.
Anyone else got anything they would like Sasha to cover tonight? Just pop it in.
Okay. So I think I can just say up front now, the big thing is age. So colic after 15 weeks of age doesn't exist. It's something else. And really consider family history of atopy. That's one of the best ways of predicting the difference between the two. But I will go into that in some more detail. So today, the learning outcomes for today are to understand the stages of infant and toddler feeding development, be familiar with current infant feeding recommendations and practices, so when we start solids and why, identify the difference between reflux and gastroesophageal reflux disease and know when to take action, understand the difference between cow's milk allergy, to understand cow's milk allergy diagnosis and management as an overview, understand how to manage simple toddler feeding problems and when to refer, and then be familiar with resources for parents, for all of the above. So as we go along, if you have questions, I'm quite happy to field them as we go or save them till the end, whatever works for you. Pop them in the chat or pop your hand up, and then thank you, Elise, for keeping an eye on those. Right, feeding babies. It's an emotive topic, how we feed babies. There's lots of opinions and there's lots of feelings about this. So when people come into your clinic room, they're going to have strong feelings about what they should be doing or what they've told to be doing. And I'd like in the back of your mind to just keep in mind this one statistic. So what nutrient requirement do babies under 6 months of age and Tour de France cyclists have in common? What requirement for nutrients is the same? Does anybody know? Can anyone guess?
Oh, I
Energy.
don't. Oh, yeah, I was just going to say, I think we need a lot of calories.
Yeah, energy, that's right. So they both require about 150 calories per kilo. For a Tour de France cyclist, that's about 6,000 calories a day. A lot of them are on IV drips overnight just to get the glucose in and that sort of thing. And for babies, they need a lot of energy. So in the back of your mind, with all of these problems with feeding, cow's milk allergy and reflux and everything like that, that's on the basis of them getting in a tremendous amount of energy. And sometimes it's not that easy. So developmental stages of feeding. If you can, if we were doing this live, what I would be handing out would be some Starburst sweets so that you can practice chewing using different types of tongue movement. And this is really important. So in the first 3 months of life, babies suckle and their tongue goes in and out and up and down. And if you can imagine if you had a Starburst chewy fruit in your mouth, what could you do with that if your tongue could only go in and out and up and down? Little babies can indicate hunger and satiety, and they can self-regulate their intake. From 4 to 6 months, it's the easiest time to introduce them to varied tastes. And that's because this is a really cool party trick if you can get your hands on a small baby. But if you give them a slice of lemon to suck on before 6 months of age, they won't pull a face. After 6 months of age, they will, because they have the ability to taste bitter and sour, but before then they don't. So it's a really good time to get vegetables in which are a bitter flavor. They can recognize different expressions from their feeders, and if it's a stressful situation, if it's stressful being fed, they can pick up on that from 4 to 6 months. So after 6 months, their teeth are coming up, and what they develop is lateral tongue movement. So this changes what they're able to eat, and they can start to manage more texture, do some self-feeding, and use open cups. Now, from 12 to 24 months, this is a really key time for feeding development. And this is the time when the parents are going back to work and there's less input from health visitors and less input and support from their friends. But what is a very normal, it's an actual stage of development, is neophobia. So this is when children start toddling around. So from about 14 months of age, that's about the time when you don't need to worry about coins and bugs on the floor. They're less likely to put it in their mouth. But it's also the neophobic phase. So they're also less likely to put any food in their mouth that they've not seen before. And nobody really talks about it. Parents aren't prepared for it. And then they think that their child, who ate brilliantly as a baby, now has got something wrong with them. But they're going through a natural stage of development called neophobia. And they tend to, at this point, start to copy adults' food preferences. And that's an evolutionary thing. Helped with survival. So from 2 months, so from 2 years of age, they can cope with most textures if there's no problems with development. And they, from 3 years of age, start to copy what other kids are eating. And this is also the time from 2 years of age and at 3 years of age that they have what's called disgust and contamination fears. So no, I'm not eating that, it's dirty. No, it looks like poo-poo. I'm not having that banana, it's brown, it's contaminated. If it touches something that they've not eaten before, or they're worried about eating, then that food that what used to be safe is no longer safe on their plate. And these are all normal stages of development. So the 10 steps for feeding babies, please don't feel like you have to make any notes about any of these, because I will share the slides with you afterwards. But these are all pretty self-evident. I think there's probably nothing that's going to be too surprising for anybody here. So let's talk a bit about what age to introduce solids. So here's 2 babies. They're eating the same food, but in a very different format. So it would be helpful to maybe have a little bit of a discussion or pop something in the chat. Does anybody know what age do you start solids? Just looking to see. nobody's popping anything in the chat here. What do you think? 4 months, 5 months, 3 months, 6 months? I'll take a look. 24 weeks, 6 months. Yeah, WHO 6 months, 4 to 6 months, 6 months. Okay. What I'm going to do is I'm going to go through the guidance out there, lots of 6 months. I'm going to go through the guidance on, first of all, what complementary feeding is. So when you say starting solids, that's quite specific. When you say weaning, it sometimes gets mistaken as weaning off the breast. So if you're reading research on it, it will discuss complementary feeding rather than starting solids or weaning. But essentially it's the introduction of solid foods, and it's gradual. It should start between 4 and 6 months of age. One of the reasons is that at 6 months, certain nutrients like iron deplete, and it is development specific. So even preterm babies should start solids according to their own needs and not according to any particular time. So what I'm going to do is spoon feed you, sorry for the pun, what the guidance is and the highlights, so that you know when you're recommending when to start solids, what you're recommending it based on. So the Scientific Advisory Committee on Nutrition, which publishes most of the recommendations that we use for nutrients, says that most infants shouldn't start solids until around the age of 6 months, having achieved developmental readiness. So that's one set of guidance. And I'm going to go through the others because what I'd like you to be able to know is where the recommendations have come from and why. So 20 years ago, so the WHO said that infants should be exclusively breastfed for the first 6 months of life. And that's where we get the idea that all babies need to wait till 6 months for solids. But the reason behind this, and these are direct quotes, is that it's malnutrition that is the key issue for that, the key issue. So the reason for that guidance is that in most parts of the world, food is often nutritionally inadequate and not safe. And so the malnutrition is the big issue. And what their aim with this guidance was to reduce malnutrition, poverty, and deprivation. They made a global public health recommendation that babies in all countries in the world need to be breastfed or should be breastfed till 6 months of age without anything else. And that's to prevent malnutrition. And it's not necessarily appropriate for all babies in all countries. So Espegan said that complementary foods should not be introduced before 4 months of age, just because the gut isn't developed enough, but shouldn't be delayed beyond 6 months. So now if people are being told that they need to wait until 6 months, they may be missing some of the key stages. And then Bazaki has recommended that for those babies, and this is off the back of the LEAP study, for those babies who are at the highest risk, so the ones that have got moderate to severe eczema and one other food allergy, they're the ones specifically who should be having eggs and peanuts from 4 months of age. But you would be correct in advising that for babies to start solids before 6 months of age, particularly if they're at risk for atopy, and looking at eggs and peanuts from 4 months of age. Now, they did consider getting kids who are high risk into allergy clinic to have them skin pricked before this recommendation was made, but as we all know, it takes a long time to get a baby into allergy clinic, and they've missed this key stage. So I recommend it a lot to babies who've got cow's milk allergy and sometimes another allergy, to when they start their solids, that from 4 or 5 months of age, they should be having peanut butter and egg, as long as it's in the appropriate texture. And there's never been any kind of severe reaction that I've seen. There is a risk in it, but it's young and it's at the first exposure. It's easier to manage than when they get it for the first time. They get peanuts or eggs later on. So complementary feeding. The key thing is that you do it when they're developmentally ready. And some babies are ready at 17 weeks of age, and some babies are ready at 5 months. Some babies are ready at 5.5 months, and some babies aren't ready until they're 6 months, or sometimes even a little bit older. But there's 3 questions to ask, and you can see this quite clearly when they're in clinic with you, but you can ask it very easily if you're doing a telephone clinic as well. You want to know if the baby can support their own head, if they can bring their hands to the midline and up to the mouth, and then if they're cognitively ready. So if they're showing interest in the food and they're fixing and following when other people are eating, and ideally reaching out with their hands. So that's showing that they can connect the mouth and the hand and the eyes, and they know what's going on. So it's not sleeping through the night. There's a natural sleep progression that happens at around 4 months of age, and not sleeping through the night isn't a reason to start solids. But those 3 signs, if they're in place, and the baby's over 17 weeks of age, and they can start solids, provided that it's in the right texture. Because remember, before 6 months of age, they can only move their tongue in and out and up and down. They haven't developed enough lateral tongue movement to be able to handle more lumpier textured foods. So from 6 months of age, you can give lumpier textured foods and soft finger foods as well. So that kind of baby-led weaning that you may have heard about. So baby-led weaning, some people that I've met, parents and other health professionals, are really, really almost evangelical about not using a spoon in any form. So that's what baby-led weaning is. And it's chunks of food. The baby helps themselves, and it can only be done from 6 months because they're not developmentally ready yet for anything other than purees before that. So it's based on the assumption that self-feeding prevents obesity and improves eating habits. It's an assumption. When reviews have been made and the literature has been looked at, when this has actually really been properly studied, there's not really enough evidence that it's the only way to feed a baby. So for the most part, doing some sort of a little bit of purees before 6 months of age, if they're developmentally ready, and then some purees and finger foods from 6 months of age. I think the important thing to remember is that the spoon is not the problem, it's the feeder. So when you are spoon feeding a child, it's very easy to push more in than they're ready or want to have. So I wanted to show you an example of being a responsive feeder, what that looks like. So you can see there's the feeder with the spoon. Good modeling there. Checking for clearance after the baby's had a spoonful. Taking their time. And sharing food. So ideally, spoon-fed babies will be fed in this manner, where it's nice and easy, nice and slow. They're going it's baby-led spoon feeding. We're going to talk a bit about reflux and GORD, gastroesophageal reflux disease, and there is a difference. Can I see, is there something in the chat there?
Yes, Veronica's asked about allergies, because you just mentioned about introducing peanuts, didn't you, an egg?
Yeah.
Are allergies mixing peanut butter with breast milk from 4 months? Is this now recommended?
Yeah, so mixing peanut butter into the breast milk, or giving peanut butter whilst babies are being breastfed, is that?
Veronica, are you there? Do you want to unmute it?
What's happened, the real danger with giving peanut butter to babies under 4 is aspiration, because it's quite a thick, chunky consistency. And there has been a study that looked at the amount of peanut butter aspiration. I think it was in Australia for infants, and that has gone up significantly since these recommendations have been in place. Now, so the thickness and the consistency of the peanut butter can be a problem, and it's best mixed into something. So, mixing it into baby rice or into porridge or something like that. You could mix it with breast milk and give it like that. But the baby will have, I think it's safe to say, additional protection if they're introduced the allergens whilst they're still being breastfed. So if the question is about consistency, then yeah, you could mix it with breast milk, but it's also really good to give the allergens whilst the baby is still being breastfed, to help with them, to help them manage that.
Thank you. That's brilliant. Thanks, Sasha.
So reflux and GORD. It's a tricky area because most babies spit up, or not most, almost most babies. And this happens to everybody to some extent, no matter how glamorous you are. So even Victoria Beckham, you can see that about 41% of infants aged 3 to 4 months will spit up after most of their feeds. And this drops off. Now, it drops off because of lots of different reasons. One of them is that the baby is more upright. They have gravity's working for them rather than against them. And also, as they start to have more solid foods, it thickens what's in the stomach and less is coming up. As they get older, it reduces in incidence. The first line advice is to avoid overfeeding, and this can easily happen with bottle-fed babies. And sometimes parents really need to have advice on that the bottle feeding should be baby-led. Smoking or avoiding smoking, winding appropriately, keeping babies upright, and not having tightness around the abdominal area will help. And then the big one, I think, is that most babies do prefer to be carried. So baby carriers and keeping the babies upright is a really helpful thing. Now, what happens is when the reflux is really bad, what you have is parents who are carrying their babies around all the time, day and night. Moms and dads are taking turns keeping the baby upright all the time because they just can't cope otherwise. And so it's important to encourage it, but not to use it too much to the point that everybody's exhausted, if that makes sense. And you may have seen parents like this who are dealing with refluxy babies, and they are not sleeping at all because they're both working so hard to keep the baby upright and feeding little and often. But that's the first line advice. So when to worry. And I have at the end in the references put the links to the NICE guidance for reflux as well. But the big one is growth faltering. If they're vomiting so much that they can't maintain their weight, then this is an issue, and it really does need dealing with. If they're in a lot of pain, it needs dealing with. And the big one is back arching. So what you see is the baby will arch their back, or parent will describe the baby arching their back and turning their head. And that's to close off the esophagus to stop the reflux from coming up. And they're in a lot of discomfort. So one of the questions you can ask is, if parents will use the term, they will always use the term, or very often use the term projectile vomiting. My baby is projectile vomiting. And in my experience, it doesn't mean how far it's going. It's not this kind of reflexive vomiting. It could still be reflux. Projectile vomiting to most parents, what that means is it's a lot. It's a lot comes out. And I've even had parents try and measure it with measuring cups. It's disgusting. But the question to ask is, when they reflux, are they upset? Does it make them cry? Are they in pain with it? And sometimes babies can be in pain even if it's not coming out, so they've got the silent reflux. But one of the key things is they're back arching and they're turning their head, because there's a lot of discomfort. They tend to be really difficult to feed, so they need a little bit and often. When they breastfeed, it's 5-10 minutes. If they're bottle fed, it's 1-2 ounces. They're just taking enough to fill the stomach, but not so much that it comes up and causes discomfort. So they're the little and often. And again, those amazing parents that are carrying their babies around upright all day and all night and are feeding every hour, and feeds run one into the next, are managing it. And then maybe the baby isn't growth faltering because they're doing so well with it, but it's still a problem. Consider also as well, if you've got an atopic family, then the reflux might be caused by cow's milk allergy. And then any of the kind of red flags as well. And if reflux is past 12 months of age, that's unusual. You remember from the graph before. So just, there was a point about growth faltering there, and I thought I've put a growth chart here. So this is the baby growth chart, the infant growth chart. So this little one was born just under the 50th centile. And you can see at 6 months of age, he was just under the 9th centile. So is this growth faltering? What do you think? Comments? No? It's just on the line. So in the reference, I've also put the nice guidance on growth faltering, but essentially, if a baby's born small, so if their birth weight is below the 9th centile, we really only want them to drop no more than 1 centile. And if they're in the middle, it's a drop of 2 centile spaces or more. And if they're born big, they can drop up to 3 centile spaces. So that baby in the previous slide had dropped exactly 2 centiles. It's just on the edge of growth faltering, but going up or down 1 centile space is completely normal. I think gone are the days when people were in with their health visitors every week, getting their babies weighed, and you could see this lovely kind of sawtooth pattern on the red books. They're just not getting weighed as often, but that's what you're looking for. So when it comes to reflux, whether it's just normal spitting up or whether it's problematic GORD, what I would suggest is first consider solid intake, because it's tremendous the difference that this can make. And really, for those babies who are really refluxy and a lot of discomfort, maybe they've got cow's milk allergy as well, usually about 3 months of age is the worst time. And that's when they're probably banging on your door and wanting lots of appointments. And one of the best things you can do is, if they're showing the developmental signs that they're ready for solids, is from 17 weeks, is allow them to have a little bit of pureed solids before you treat with medicines or anything else. Encourage them to have a tiny bit of pureed food, and that does make a world of difference for refluxy babies. So you can use thickeners. Carabal's one that's commonly used. Now, what I would say is, if your baby reacts to Carabal, and particularly if they're milk allergic, about 50% of babies who are milk allergic also have problems with soya. And there's some sort of cross-reactivity between Carabal, carabine, and soya. And so what I've often seen is that the babies who react to Carabal are going to have problems with soya. But it is there, and it is useful for some babies, particularly if they're not ready for solids. You also have anti-reflux formulas, and then there's the hypoallergenic formulas. So it's worth trying 2 weeks of dairy-free. If the baby's breastfed, mom can go dairy-free. And if not, you've got the extensively hydrolyzed formulas. And depending on what center you work with, some will say that moms who are breastfeeding, where you're suspecting cow's milk allergy, their baby's really refluxy, they're uncomfortable, all the first line treatments haven't worked, the solids haven't worked, Carabal hasn't worked, anti-reflux formula hasn't worked. If you do try, going dairy free. Some centers will say go dairy and soya free because about half of them will have problems with soya as well. It's quite difficult to do, so they do need some support.
Sasha, we've just got a question.
Yeah.
Okay. Yeah, Greg's just asking about the Carabel. Can it be used with express breast milk?
Yeah, absolutely. Mm-hmm.
Is it easy? You just mix it. Does it just tell you on the packet? I haven't used that one.
Yeah.
It just tells you how much to mix in, does it?
Yeah. Instructions on the packet.
That's what we like. Thank you.
I think years ago, and still today, some people, they're putting baby rice in bottles, and it kind of it acts in the same way. But really the first thing probably should be some pureed solids from 17 weeks of age. Once all the other stuff has been considered. There's other guidance as well about raising the head of the bed, although it's a little bit controversial. Some people say that it doesn't work or shouldn't be done, but there are other things out there. And there's a really good website called Living with Reflux, and it's a charity that was started by a pediatric gastroenterologist, and there's loads of good information for parents on that. So this is the allergic march. I'm just wondering if this is familiar. Is this something that you've seen before?
No, I don't think I've seen it.
So what it is it's the prevalence of allergies in childhood and beyond. And it's the natural history of allergies. So we know that babies with eczema, with allergic eczema, are more likely to have food allergy. And but they tend, and the first and most common food allergy is cow's milk allergy. And the natural history of cow's milk allergy is that the rates start to drop off after the first year of life. They kind of tend to outgrow it between 1 and 3 years of life. Eczema tends to last a little bit longer, doesn't it? Till about sort of 3-5 years of age on average. And what inevitably happens is a baby outgrows some milk allergy. They've gone through the milk ladder. October comes around, everybody turns on their central heating and the air dries out and their eczema comes back, and parents think that they need to cut cow's milk out again, or they've somehow developed another food allergy. And often it just has to do with management of eczema more than food allergy. So later on, from kind of, is it about sort of 4 or 5 years of age, you get allergic asthma, and then into the teenage years, allergic rhinitis. Now, some people would say that there's even a fifth curve to the atopic march, which is IBS. But certainly this is the natural history of allergies as you'll see it in your patients. We know allergies are on the rise. A lot of these statistics are quite old. And I imagine that the incidence is even higher, the costs are even higher now. Does anybody know why allergies are on the rise? Allergic conditions are on the rise? Okay, so genetics. And then there's a hygiene hypothesis that babies are born with this incredible immune system ready to fight off everything, and they don't have anything to fight off. So if you look at places in developing countries, they still have the same genetic predisposition to atopy. They still have the same rates of allergic rhinitis, but they have lower rates of food allergy because the baby's immune systems are just busier from birth. There's also the idea that the microbiome is involved, and I mean that's a huge topic. That would be an hour in itself, really. But with the increased use of antibiotics and C-section births, so the changes in microbiome formula use, this can all affect children's chance of having allergies or food allergies. We know that eczema in infants is related to food allergy. Vitamin D deficiency can be related to asthma, and then obesity, of course, is on the rise, which has an impact on asthma in our children. So cow's milk allergy is really prevalent. The numbers are quite low when you look at that, prevalence of 0.5 to 3%. But the problem is that a lot of the studies where they're looking at prevalence of cow's milk allergy, they're looking for IgE-mediated cow's milk allergy, and that is by far just the tip of the iceberg. The vast majority of babies and children with cow's milk allergy is non-IgE, and it's delayed. So the symptoms show up 2 to 72 hours afterwards. And it's very difficult to diagnose. So it tends to be in the studies on milk allergy, they're looking at IgE. And I think the key thing here is that it occurs consistently with ingestion. Now, for babies who are bottle fed, that's a little bit easier to tell because the bottles are completely cow's milk based. Now, in a breastfed baby, there's a lot of variability. So cow's milk can get into the breast milk, and babies can have reactions. Babies can have cow's milk allergy when they're breastfed, but it depends a lot on how much milk or dairy the mum is eating. And so with the rise of vegan eating and the variability between people, some mums are drinking tea all day with milk in it, some are vegan, some avoid dairy for other reasons, and it's difficult to tell unless you really ask them what they're having. But so it might be that some babies who are breastfed, if mums have no dairy most of the time, and then all of a sudden they have a pizza, their babies are going to react after they have those next breastfeeds, but not necessarily throughout the day. So it's a little bit tricky to diagnose it in breastfed babies, but not impossible, and certainly should be considered. So has anybody seen this, the MAP guidance? Yeah. If you look at this and feel dizzy, that is normal. I still look dizzy when I look at this, and I still look dizzy. I feel dizzy when I look at this. And I was at a conference once where a pediatric allergist from a major children's hospital said that the guidance was nearly impenetrable. So if you have the time to really piece through it, it's worth looking at. Everything you need to know is there. It's a very good piece of guidance, but I thought I'd give you the highlights about cow's milk protein allergy. So number one, it's not lactose intolerance. You'll have lots of parents coming in thinking that their baby has lactose intolerance because it's just a more familiar word. And globally, 2/3 of the population are lactose intolerant, not so much in Northern Europe, but in babies, lactose intolerance is very, very rare. Excuse me. You can get galactosemia, and you can have sometimes a secondary lactose intolerance after a bad bout of gastroenteritis or antibiotic use or something like that. But cow's milk protein allergy is very different. It's an immune reaction to the protein in the milk. It's always important to consider family history of atopy. You can have cow's milk allergy in babies whose parents have no atopic disease whatsoever, but more often than not, when they come into your clinic, the baby has got these symptoms: loose stools, constipation, wind, reflux, sometimes rash, but not always, and sometimes growth faltering, but most of the time not. But then when you look at the family, mom's got allergic rhinitis, dad's got a wasp allergy, the siblings got eczema, they're atopic families. And so it's always worth considering cow's milk allergy in babies who are not settled or have their kind of traditionally colicky symptoms, and they come from allergic families. Remember, the vast majority are non-IgE, and so the symptoms don't show up immediately. You're not going to have any lip swelling. You're not going to have any rash, or you sometimes can have vomiting, but it's more of a reflux kind of vomiting rather than a immediate type of vomiting. Mums still can breastfeed when the babies have milk allergy. They need to cut out dairy and sometimes soya. Do this for 2 weeks and then reintroduce. If they're formula fed, the first line is extensively hydrolyzed formula, and I've put the names of the most common ones there. The last time I looked, I think Alimentum was the least expensive of the extensively hydrolyzed formulas, but it's still fairly expensive. So if parents can continue to breastfeed and be supported with that, that's really best for everybody. The second line, so it does happen. It used to be 15, 20 years ago, Neocate was the only cow's milk free formula really that was available, and we gave it to everybody. But it's elemental and it's not required by the vast majority of babies with cow's milk allergies. So there's some other elemental formulas now, and it does happen sometimes when babies are so reactive to the cow's milk that the first line doesn't work. So they're better, a bit better, but not really better. So you can try them on elemental formula, but they're considerably more expensive and they taste a lot worse, and they're thinner generally. So for babies who are refluxy, sometimes that can make things worse.
Can I just ask something, Sasha? Would that be all right? I actually messaged you about this, didn't I? But I had a mum come in who thought her child had cow's milk protein allergy. She was breastfeeding. She cut out dairy. Then she was asking me about whether she should cut out soya, but probably, on balance, maybe she should if 50% have reactions. And then she was asking, because baby had got a lot better, but then having a few episodes where she didn't seem so settled, and mum ate a lot of eggs, and she was asking me whether she should cut out eggs. Do you mind just mentioning that? Thank you.
Yeah. So eggs are another protein that can pass into the breast milk. So milk, soya, wheat, eggs, peanuts, they can all get into the breast milk, and they can cause a reaction. But the problem is that parents often want to try cutting out more and more and more, when in actual fact, it's really hard to cut dairy out, and it's in everything. And soya as well is in so many things. And some babies are so reactive that if mum eats some biscuits that have no dairy in, no soy, but maybe a little bit of soya lecithin in, their baby gets unwell. So the key thing is to make sure that they've cut all the dairy out. And that's one of the things that we would do as dietitians when parents get referred in. So make sure they've cut all the dairy out. Consider soya as the second most likely culprit. Eggs can be a problem, but more often than not, it's anything that you eat eggs with probably has dairy in, or parents have not properly cut out the dairy. So it's something to consider, but every time you cut out a new food, there's additional nutritional risk. So it's less nutrition for mom, and then potentially one fewer food that the baby is going to be introduced to when they start solids. And we know that it's a good idea to give eggs sooner rather than later.
Thank you.
Yeah. Of course, we love it when you refer to us, and the sooner you can refer to a dietitian, the better, really, because if parents have got the information before they start solids as to what they're doing, things generally go smoother. And then eventually we'll be talking to them about the milk bladder reintroduction. So good, we've got 15 minutes. So we can talk about toddler fussy eating. It's a big problem for a lot of families because it's a natural stage of development. But at what point does the natural stage of development actually become a problem? I think the key thing is to manage expectations with parents, because when you go to a restaurant and you order a child's meal, and I've done actually analysis of this, but children's meals today are the same size as adult meals used to be 70 years ago in restaurants. So what I think a lot of parents struggle with is they think that their children need to be eating a lot more in volume than they actually need. And so one good guide is your two hands. And so what I often say to parents is, if you put your two hands together like that, kind of like a cup, that's about the size of plate that you need as an adult. That's how big your stomach is. And your kids' hands, if you put them together, that's about the size of plate that they need. So a sprig of broccoli or a quarter of a slice of toast for a toddler could be completely adequate. And parents think that they need to be eating a lot more. So that's kind of a basic thing that you can talk with them about, but also let them know it's a natural stage of development, that they're supposed to be a bit fussy and they need to see the adults around them eating and enjoying food. So the whole issue of fussy eating with toddlers is tricky because sometimes it is actually problematic. So if you get a toddler who is going through the normal stage of development, the neophobic stage, and they get an illness like tonsillitis or gastroenteritis or something more severe and they're in hospital, they can lose a little bit of weight, parents can get really worried, and then the issue is not just that they eat and they feel unwell and they're naturally neophobic, but now they've got parents who are really, really worried and are trying to feed them anything that they'll eat. And the child learns that they can refuse like dinner and get a treat or a packet of crisps just because the parents are so worried. So now what you've got is a normal stage of development, the kind of problems and pain associated with eating, and then a behavioral reinforcement. And some of the most tricky feeding problems that I've seen in toddlers have been that sort of perfect storm of situation. But let parents know neophobia is normal. Discussing contamination from 2-3 years of age is normal. And they need repeat exposures and they need modeling. And if you only have 1 minute with a parent or 2 minutes or whatever to describe this, one of the kind of little stories that I use a lot with parents, and it seems to resonate with them, is describing that children are predisposed not to like vegetables. They're green and they're bitter. And so we're genetically predisposed to not eat things that could be poison. And that's why children don't eat they don't eat the houseplants. And unless they've got pica or Prader-Willi syndrome or something like that, or some kids with learning difficulties, maybe. But for the vast majority of children, they're not going to eat the houseplants. They might eat everything else, but they won't eat the houseplants, even as babies. So the difference between a poison and a broccoli is not obvious to a baby or to a toddler. They need to be modeled that. And how you can describe this is if we were all hunter-gatherers and we took our toddlers out into the forest, and my toddler ran around and ate all the berries and ate all the leaves and dug up all the roots and chewed on those, and your toddler was really, really hesitant, wouldn't eat anything that it hadn't seen before, wouldn't eat anything unless it saw you eating it, a trusted adult, and if they put it in their mouth and it tasted bitter, or if it was green and they spat it out, your baby would be much more likely to survive than my baby who was indiscriminate and ate everything. So it is a normal stage. And what they need is to be modeled that the food is safe. And what toddlers inevitably do, and they do this all the time, they hold their food up to you and try and feed you, right? And a lot of parents think that that's a game. They think that, oh, it's a bit of fun and I'll pretend to eat this. But it's not a game to the toddler. It's a life or death question. They're asking you, Mom, Dad, Grandma, is this safe? If you eat it, I'll eat it. And that's why toddlers want to eat off your plate. because if it's on your plate, it's safe. It's the same food on their plate, but they don't know that. So they really have to be taught that things that we know is food because they just don't know it. And also, if they've had baby food right up to their first birthday, and then they start on solids that they've never seen before, that's also going to be a really big problem. So it's ideal for them to have little bits of it throughout their baby months as well, so they're ready for it when they're a toddler. Another thing that is useful to think about is the feeding relationship. And so there was a dietitian and a psychotherapist in the States a few decades ago who wrote lots of books on this feeding relationship. And essentially, and this really can empower parents, because a lot of times the feeding relationship is completely dysfunctional in kids with fussy eating. So the feeding relationship is this: the parent decides when, where, and what food is on offer, and the child decides how much or whether to eat it. And what often gets upset in this relationship is the child is kind of going to the fridge or going into the snack bag and taking the food out and deciding when, where, and what they're going to eat. And then the parent sits down at the meal with them and tries to get more food in. So as long as the feeding relationship is balanced, then parents can be kind of rest assured that they're doing what they need to be doing. And the other thing to do is to really engage your kids with food without the pressure to eat. And I think one of the best ways of looking at that is to Google something called the steps to eating. So there's actually 32 steps, and lots of parents think that they haven't succeeded until the child has put the food in the mouth, chewed it up, and swallowed it. But in actual fact, there's 31 steps to eating that need to happen before that. And it starts with just being able to look at a new food. So for some kids who are really, really aversive feeders, they struggle to look at new foods. They struggle to have the food on the table. And they certainly would struggle to touch it, smell it, swish it, put it on their elbow, put it on their cheek, put it on their lip. Those are all, some of the steps leading up to that. And it's worth having a look at if you're dealing with anyone who's a particularly fussy eater. And that's not just for toddlers. We use that for school-age children as well. The Infant and Toddler Forum website is really good, and as is the Loughborough University Child Feeding Guide website. So 10 steps for feeding toddlers. This is, again, from the Infant and Toddler Forum website. It's a really good source of information. And at the end, I've got a list of websites that you can hand out to parents, but when to refer. Now, it used to be, when I started in Chesterfield, it was about 15 years ago, we took any wafer stray that anybody referred us, but it's all changing now. And it's the key one is going to be faltering growth. So if their weight has dropped 2 or more centiles, that's key. If they're not feeding well and they're not growing, that's key. Please refer. If their reflux is really uncontrolled, if they've got pain, discomfort, or if they're older than 12 months and they're still refluxing, please refer, ideally to a pediatrician. Another thing that you can look for is if the baby's in your clinic and they're feeding, whether it's bottle or breastfeeding, there should be a coordination. They suck, they swallow, they breathe. Suck, swallow, breathe. So they should be able to do that in a fairly rhythmic manner. There shouldn't be any lip spillage. And then if they're having any problems like that, or texture refusal, choking, those kind of things, you can refer to a speech and language therapist for a feeding assessment. Now, the other thing that I think is one of the key predictors to whether or not you've got a clinically significant feeding problem is how long a meal takes. And there was one review that I looked at, and one of the best predictors of whether or not a child had a clinically significant feeding problem was how long the meal lasted. If it's regularly lasting longer than 30 minutes, that's a good sign that there's a problem. And I'm not talking about, a continental family where they've got courses and courses and courses, and the child's happily sitting there for 45 minutes and engaging and eating. It's not that. But if parents are battling for more than 30 minutes 3 times a day, that's a problem. So we always say, limit your meals to 30 minutes. Whatever they haven't eaten, remove it. Don't make any comment. But if you're seeing that and hearing that, it's a huge burden of pressure on the parents and on the child. And then also, if you see any kind of significant distress, if the parent is really, really upset when they're talking about whether the child won't eat, or if the child at meal times gets really upset, that's a reason for referral. Okay, so a bunch of references there. Like I said, I'll share the slides with Elise to share with all of you. The ones I've highlighted are the key ones. If you want to really geek out, you can read the other ones, but those are the key ones to look at for allergy and for reflux as well, and feeding problems. So I've done this as a PowerPoint slide. It'd be quite easy to just run off a load of copies of these. So if you've got somebody in your clinic and they have got cow's-milk allergy, those are the two best websites to go to. I think there's excellent information on Allergy UK and patient webinars. Living with reflux is amazing for babies with reflux. It is designed specifically for babies. And then there's lots of stuff there on fussy eating.
That's brilliant. Thank you so much, Sasha. I genuinely found that so interesting and just wished I'd heard that before I had all my children. Sasha, we've got a question from Greg. He's just saying, when you say lip spillage, because that was one of your last slides, wasn't it? Mm-hmm. Is that more than the normal dribbles?
Yeah. So, well, if they're dribbling because they're refluxing, or spitting up or something like that, that's fine. That's normal. But when they're actually feeding, there shouldn't be that much that's coming out. Not regularly, not routinely, not each time they feed. And certainly as they get older, so for toddlers and things like that, they should be able to close their mouth and chew and not have stuff coming out. But it's all something that a speech and language therapist could assess and advise on.
That's brilliant, thank you. Has anyone else got any questions or anything? Feel free to unmute or pop it in the chat. And Sasha, I just wanted to ask you, I'm seeing a few children who are 3, 4, 5, whose parents are coming with issues about restricted eating that you were mentioning. So they're not necessarily losing weight, the child is okay. Occasionally there's been mums, saying, oh, maybe there could be some aspects of autism here, but not significantly where they've sought referral for that. The websites that you mentioned, are some of them good for that kind of older child? Just for...
Absolutely, yeah. So what I would say is actually what I haven't put on here, but I will before I send it out to you, is the patient webinars website has got some really good stuff on fussy eating.
Oh, brilliant.
Really, really good. And it talks about what to do, it talks about food chaining, all of those kind of things. So it's really useful. And certainly kids with autism or kids who are developing ASD or those with sensory issues without autism are more prone for feeding problems because they just like things to be the same. They like nice uniform textures, beige colors. They just don't want too much sensory input.
Okay, that's brilliant. Thank you. Yeah, if you don't mind putting them on, that would be so useful. Julia's just asked, when do you give Gaviscon and omeprazole for reflux? Parents often come requesting this.
Yeah, sure. So I should say I don't give Gaviscon or reflux because I don't prescribe, but I can tell you what I see. So if you give Gaviscon, you run the risk of them being constipated. If you give omeprazole, it's not a great first line. So they often come wanting it, but if you've ruled out cow's milk allergy and you've suggested starting solids at the right age, you can give Gaviscon, but sometimes it causes other problems. So Gaviscon, you can give right from being a neonate. Omeprazole I've seen in quite young babies as well, but you usually have to have tried some other things first. So I'm trying to think what the earliest age I've seen a baby on omeprazole. Not sure what the prescribing guidelines is on that, but
I think often we will refer the paediatrician, well, in my experience, the paediatricians have started that on babies I've ended up referring, because we've tried lots of things and things haven't been getting better. Right, well, has anyone got any other questions? Otherwise we're about on time. Can't see anything else coming through, but that's brilliant. Sasha, genuinely, as I said before, that was fantastic. I've really, really, really enjoyed that. So I will send out your slides. Thank you for offering that as well. So I'll send I'll forward them to Amy during the GP Task Force office, everyone, and she will send them all out to you. As usual, we'll also be sending out feedback forms, because then we'll be able to give Sasha feedback. And Amy has set up a new spreadsheet, everyone, which is very exciting. It will automatically send you your certificate. So, I mean, if that's not an inducement to fill out feedback, I don't know what is. But if you do have any issues with that, again, let us know. We've got some great sessions coming up next month. We'll put them, well, I think they're already on the website, but we'll be sure to advertise them. One of them is on dementia, so that should be really good. And thank you again, everyone, for joining us. As Sasha said, evenings are precious, so thank you so much for joining us today, and particularly thank you to Sasha for giving up her time, just from the goodness of her heart. So thank you.